Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. It's blessed to us to start our session today with Umul Kitab Al-Fatihah. Good morning to our Dean, Fakulti of Medicine, Raja Effendi Raja Ali, all the heads of departments, all the professor and lecturer, and my beloved student. It is an honor for us from Advanced Foot and Ankle and Diabetic Foot Services, Department of Ortopedik and Traumatology, to be presented in this Clinico-Pathological Conference with a topic of post-traumatic ankle arthritis, a new beginning instead of the end. Our speaker for today will be Dr. Safari bin Zulkifli and Dr. Ong Shir Lee, the registrar of my team, Dr. Tarmizi Musa from Surgical Department, Ms. Tana Ai from our physiotherapy unit, and Ms. Noliana binti Mazdi. So without further ado, I will just outline our presentation today. It will be started with a case presentation and then followed by a radiological description, case discussion and management, rehabilitation and physiotherapy, and it will end by a Q&A sessions. Okay, without further ado, I will invite Dr. Safari bin Zulkifli to start our case discussion. Thank you.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Thank you, Prof. Yazid, for giving me the opportunity to present for our Clinico-Pathological Conference this morning. So I will start our presentation today by explaining and introducing our patient. Madam SHSN is a 23-year-old lady with no underlying medical illness. She was a student and pre-morbidly patient is ideally independent, loves to play badminton, and used to do regular jogging in the evening together with her friend. Unfortunately, patient had involved in motor vehicle accident, which was occurred about 3 years ago, and she sustained closed fracture right tibia plafon, closed right meniscal femur fracture, closed multiple right intertarsal bone fracture. At the point of time, patient had underwent plating of the right tibia, interlocking nail of the right femur, and K-wiring of the foot metatarsal. However, it was not stopped by that. Even thorough wound dressing, patient had underwent multiple wound debridement, especially at the area of the anterior ankle, and subsequently patient had developed chronic wound at the right ankle region, which was take about 2 years to heal. Thus, this impeded the rehabilitation program of the patient, and patient was subsequently complained of chronic ankle pain with deformity. Due to the young age and patient was pre-morbidly active, patient was referred to Foot and Ankle Team UKMMC about 1 year ago. According to patient, the ankle pain was excruciating in nature. It was aggravating by mobilizing and need to use ambulation with crutches. The pain score was 7 to 8 out of 10, and it is associated with swelling. However, there was no sign or symptom suggestive of infection at the current point of time. There was no fever, no any other elsewhere bone pain, and patient are deemed to take analgesic, which was told about 2 to 3 times per week, and to reduce or to control the pain, and it required a lot of rest. In this case, patient had low self-esteem, depressed, and had reduced activity, especially socializing with friends, and it was so stressful to the patient. This ankle deformity, she as well had deformity of the ankle, and it was so troublesome until patient wanted to seek for further attention and management for the right ankle region. Upon clinical examination, patient was well nourished, not septic looking, not sick, and clinical examination of the right hip, right knee was unremarkable with full range of motion. And however, clinical examination of the right ankle shows patient was unable to do heel strike, squat, forming single leg stand, and it was kept in equinovarus position, whereby it was 20-degree equinus, 50-degree varus. As you can see in this clinical picture, there was extensive scar, which was fibrotic hypopigmented at the anterior aspect of the right ankle region, which is about 10 to 10 centimeter. However, there was no any evidence of cellulitis, punctum, discharging sinus, or any evidence of fogginess around the area of the scar. Blood investigation was performed at the time, and there was safety parameters. For example, total blood count, CRP, ESA was normal, and the rest of the blood parameter was unremarkable. So in this patient, we can foresee there is several issues that we need to be tackled physically, psychologically, and we need to meet with the patient expectation. Psychologically, patient had been expressed low self-esteem, depression, and feel loss of hope. As this patient is still study in our local university, it had difficulty in focus, and it was a very hard time for the patient. So patient expected to have a painless ankle, and she was hoping that it will not depending anymore on the working aid for ambulation, and able to participate in sport activity and especially graduate on time. So what to do next? Is there any hope for the patient? Is this the beginning or is it the end? I will proceed our next presentation with Dr. Tamizi. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. My name is Ahmad Tamizi Musa. I'm a neurologist, associated imaging in PUAN. So for the we'll start with the radiographic imaging. So this is a basic imaging for assessment. What we need to do, what we need to know about the imaging is firstly have to know where are the locations involved. Okay. How much does it involve? The part of the alignment. Okay, we can see the alignment of the talus is tilted to the medially, and then part of that we have to assess the articular space in the any sclerotic appearance, which is you can see here there is sclerotic margin overlying that. Okay, due to the collapse of the tibial medial aspect of the tibial platform. Okay, and then we have to see is there any widening of the joint space. You can see here there is widening of the joint space of the lateral aspect with intraarticular fragment. On AP view, there is anterior subluxation of the talus itself. And then for we also have to see is there any plate or screw. It's not plate and screw within this radiographic imaging, but we can still see part of the holes that present there. Don't forget to assess about the soft tissue. You can see here soft tissue swelling on the medial aspect of the joint and anterior and posterior aspect of the joint itself, keeping with some vision. In the weight-bearing imaging, we have to assess part of the alignment between the talus and metatarsals. Okay, there's still preserved here. We have to assess the beholder angle. Is there any improvement of the cartilage itself? And also from the AP view, from the weight-bearing, you can still see the widening of the joint and tilting of the talus itself. Then we have to go for the assessment of the ligaments. MRI is the best. In the ankle, they have three components: syndesmosis, medial and lateral ligament. I will tell about the medial and lateral ligament because this is part of the main component that is stability of the ankle. So lateral ligament have three components, which is LTFL, CFL, and also PTFL. Okay. And the medial ligament have a complex component, have a deltoid ligament, have superficial and deep deltoid ligament. For the deep deltoid ligament, okay, it have anterior tibialis and posterior tibialis, which communicate communicating with each other. And then part of that, the superficial deltoid ligament is between the tibio-calcaneum, which is connected to the susun thalli, tibio-navicular, and tibio spring. Okay, communicating between the spring ligament to the tibia. This is example of the appearance of the in MRI. You can see this is a part of the anti-AITFL and PITFL down there. As we go down, okay, we start to see part of the ATFL emerge here. Okay, on the medial aspect, we start to see the superficial part of the deltoid ligaments. Okay, which is tibio-navicular. Okay, as we go more down, we start to visualize more of the ATFL and PTF down there with deep deltoids that are present here. This is the posterior tibial. As we go more inferiorly, the lateral and medial collateral ligaments start to emerge as being present there. So it's not complete to assess the ligament without seeing the in corner view. So in the MRI, we always see in the corner images. Okay, part of the tibio-navicular here, and then from the anterior to posterior, and then go more posteriorly, we start to see this is the tibio spring communicating between the tibia and a spring ligament down there. Okay, holding on to the talus, and tibio-calcaneum. Okay, communicating between tibia and calcaneum region. For the lateral part, we can still see the AITFL and ATFL communicating between the tibia fibula and also fibula and talus itself. As we go posteriorly, we start to see the TFL here and also the PTFL on there. So how about our patients? So in our patients, we start to see part of the tibia, middle aspect of tibia plafon start to crumble there. Okay, with a lot of the fragment appear there. Anterior subluxation of the fibula start to emerge. Okay, present there. PTFL present. Okay, but AITFL is not present anymore. Okay, from here we start to see part of the tibia navicular and spring ligaments present, but appear high in intensity, means some anomaly already there. And from here, tibia calcaneum can be visualized at this region. As we go down inferiorly, okay, we start to, from here we should see the superficial bundle of the ATFL but not present anymore. As we go more inferiorly, okay, we start to see part of the PTFL down there. Deep deltoid ligament is not present anymore, that will be fractured. That will be there. As we go more inferiorly, we start to see part of the CFL here, going posteriorly and committing to the calcaneum itself. So as we go, so it's not complete to assess the patient in the axial view. We have to see in the axial images. From here, we can see the tibia spring here bulky and high in intensity, means have some injury spring, and tibia can also have a similar appearance also. Definitely ATFL is not present with spring of the CFL down here. Then we need to assess the cartilage. Okay, this is normal cartilage for the normal patients. We have a preserved zonus in intensity. Okay, interface between the tibia plafon, talar dome, and subtalar joint also. You can see, visualize the zonus in intensity, different contour appearance. This is the grading of the chondral injury, and also chondral injury in the talus. The recovery can be graded by this grading. Grade 1, most of the time is defect at the involving the just edema, with some have a high intensity, not swollen. Or when you say grade B, it means some fracture involved the cartilage. As you go, grade 2, there is separation of the cartilage with the subchondral. Grade 3 is very swollen of the or softening of the cartilage itself. Okay, with verbal collapse of the bone. And grade 4 is there is a complete fissurings, okay, but still not separated from the bone itself. And grade 5 is the separated bone. As in our patient here, we can still see part of taladum preserved, but however the perform on the major aspect is collapse with some fractures overlaying there. Frequently, there is possible as some avascular neoplasy that already happened in this component itself. So as for the radiological imaging, the radiograph should be essential for primary assessment. MRI should be used to assess the soft tissue such as ligament and cartilage, and with good equipment, we can assess it better. Thank you.
Now our impression will be a post-traumatic osteoarthritis of the right ankle joint, secondary to closed fracture right ankle joint. I would like to invite Dr. Shir Lee to give some discussion about this issue.
Hello, good morning everyone. I'm Shir Lee here. So before we start our discussion, let's have a quick recap about ankle joint. Ankle joint is made up of 3 bones, which are tibia, fibula, and talus. It is a synovial joint that having a synovial membrane with articular surface is shown here. So it acts like a hinge joint where it have a movement for the ankle with dorsi and neutral and plantar flexion. All right. So in general population, according to this review in 2017, there's 1% of the global population having ankle OA. But any OA is 10 times more likely to diagnose in ankle primary osteoarthritis. But in these cases, it is caused by post-traumatic, where there's a 70 to 90% of ankle osteoarthritis was post-traumatic. The common trauma that happened in post-traumatic ankle osteoarthritis is ankle sprain and fracture, which is either open fracture or closed fracture, which is shown in the radiographic here. So why is it less likely to happen? This is the table that summarizes how what's the reason of primary osteoarthritis of ankle is more rare compared to knee. All right. So there's the classification that we use for osteoarthritis of ankle, which called as Takakura Tanaka, according to the joint space that's seen in these 4 stages. So what patients were presented to us? They were presented in pain when weight bearing and limited range of motion. During examination, what we can find, number 1, we can see the joint is swollen. Effusion of the joint, patient will have a deformity, and when examination, patient may present with limited range of motion or point during examination. So according to a research done in Japan in 2017, they found out 39% from their patients was complicated with anxiety, and 33% of the patients that conclude in the study have a depression. So generally what we can offer to the patient, we can divide it into non-surgical treatment and surgical treatment. So I will discuss further. In non-surgical treatment, it will include of physiotherapy, supplements, and then HA injection, where the joint injection for pain relief, and oral medication for pain. So in surgical treatment, they are divided into joint sacrificing, where we take off the articular surface in total ankle arthroplasty, or we fuse the ankle there where movement are not allowed. So in joint preserving, we'll try to realign the ankle by using supramalleolar osteotomy, or we debride it arthroscopically, and distraction arthroplasty using the external fixator, which is shown as here, that we separate the ankle joint. So what's the problem having in this patient? This patient is young, is 23 years old. She had a trauma before, and she's been diagnosed with post-traumatic ankle osteoarthritis. And due to the previous surgery having a complicated surgery, she have a poor skin and soft tissue condition. Therefore, we opted this patient for distraction arthroplasty. So according to the systematic review, there are 4 papers that conclude that there's a clinical benefit from distraction arthroplasty. So the system that we use for this patient is that TrueLogs have a support system. It is an external device that we combine with a programming before we apply this device to the patient for correction and trauma management. So this is the intraoperative photo that we taken during the surgery. You can see the foot is in supination position, and then it was elevated if patient was on the ground. You can see the arrow here, and the ankle is in equinus, and the heel was in various position. This is the body of patient. The ankle is pointed, the heel was pointed inward. So this is a comparison photo before the was intraoperatively and after during clinical photo of the foot. You can see the foot is more pronated. So this is the side view for the ankle with the device. As you can see, there's the improvement here. So this patient was on the device for 3 months in total, and afterwards she was put on a foot ankle orthosis to protect the ankle until it gained a range of motion and a good muscle strength. Therefore, we opt it. And after the external device was being off, she was being opted for customized shoes wear for this patient. Okay, then this is from my side. I'll proceed with physiotherapy for this patient. Thank you.
Good morning to the organizer committee. Thank you for this invitation. Good morning to professors, doctors, ladies and gentlemen. My name is Tanai Ai, physiotherapy from SCTM. My topic is on rehabilitation and physiotherapy. In osteoarthritis ankle, the role of physiotherapy rehabilitation is to reduce pain, improve range of motion, strengthen muscle, improve balance, coordination and stability of the ankle. Final is to improve the patient's physical function. During her ankle distraction arthroplasty, there are 3 phases in our rehabilitation approach. In phase 1, the rehabilitation starts from post-operative tear discharge home. We provide chest physio to ensure her lungs are clear. We provide guidance on technique in bed mobility and transfers, using non-weight bearing crutches, movement, and strengthening muscle above joint. Phase 2 is the outpatient rehabilitation with external fixator. Upon discharge the first 2 months, patient should ambulate with non-weight bearing crutches. On the 3rd month, patient will start to ambulate with partial weight bearing crutches. Again, this is the aim to continue improvement on mobility, muscle strength, and leading toward more functional daily activity. In phase 3, start when the patient has external fixator removed. Here, patient will ambulate with full weight bearing to continue her exercises, leading toward independent and leading a normal daily activity. These are the routine in phase 1 and phase 2, which include spirometer, cross exercises, and some isometric exercises. In phase 3 approach, working toward independent and back to normal daily activity, based on client condition assessment and consultant referral. These are the customized phase 3 rehabilitation plan, include from pain management to passive mobilization, exercise, hydrotherapy, balance and proprioception, functional exercise, gait training, and some other external support devices. In pain management, object is to warm up tissue, relax stiff joint and muscle. Co-pad is to reduce inflammation, pain, and also swelling. From hot to cold pad, electrotherapy such as transcutaneous electrical nerve stimulation is to use to reduce perception of pain. Soft tissue mobilization. This is a massaging approach. It helps to improve local circulation, enhance joint flexibility, and relieve pain. During the treatment, she was hypersensitive to touch, especially at the scar area. In physiotherapy, this is defined as complex regional pain syndrome. To address this challenge, we use spiky ball massage to desensitize the pain area. Passive mobilization was used to improve her range of motion on the joint and also to decrease the adhesion on the scar. Mobilization done was plantar flexion, dorsiflexion, inversion, and eversion of the ankle. Well, passive mobilization was done by the physiotherapy here. She has to do the same movement on her own. Ankle dorsiflexion, plantar flexion, ankle circle, here lift and toes raise and here drop on the step. Strengthening exercise is a resistance exercise. The pull and the resistance will improve muscle tone and strength. These are the strengthening exercise. We have to do, example, strengthen tibialis anterior with the TheraBand or using the ankle top strap. Endurance exercise is to build out her overall fitness, confidence, and to get back into a normal daily activity. Hydrotherapy is suitable during the inflammation and the painful stage. Water biosis and the anti-gravity property in water help in partial weight bearing. The heater pool provides a relaxation environment and increase the range of motion. The water resistance also help to improve muscle strength and endurance. Balance and proprioception training is also important to reduce risk of fall. So this exercise is focused on improving the ankle stability. Airway cushion and bobble board are some of the examples of equipment used for the ankle stabilization exercises. Functional exercises is toward the end of her physiotherapy rehabilitation program. Here, we guide her toward building her confidence and getting her back to her normal activity daily living. Examples are standing on one leg, heel and toes walking on uneven surface, and others. Before client is discharged from the physiotherapy rehabilitation program, gait training and assessment are carried out. Due to long period of limited movement with abnormal gait, we therefore have to help her correct her gait. The emphasis on gait training is very important because we want to lower her risk of fall, recurrent injury, and losing confidence in moving around again. External support devices are used in some cases for proper foot alignment. For this client, Professor Dr. Yazid has prescribed her an ankle foot orthosis. This is to support her ankle. After she has gained good range of motion and muscle strength, she was also given a custom-made shoe. In conclusion, she has successfully completed her physiotherapy rehabilitation program. she is back to work, working well, and leading a normal daily activity. I take this opportunity to congratulate Professor Dr. Yazid Bajuri and his team for their successful management of this client. I also want to thank you for referring her to our physiotherapy unit. With that, thank you very much for your attention.
Thank you, Ms. Tanahai, for very well described on the rehabilitation part of the patients. So I think as we already completed the physiotherapy and rehabilitation part of the patient, I think we should know how the patient is doing now. So I would like to invite Ms. Noliana to tell us about how is the patient now and give some conclusion about our treatment towards the patients. Ms. Noliana.
Thank you, Prof. Yazid. Good morning, Assalamualaikum, and good morning, everyone. So I will continue presenting the follow-up part. Currently, this patient is already 18 months post-operation. These are the X-ray taken during the follow-up. This is the post-operation X-ray. You can see that the ankle is in varus deformity. And at the end of the treatment, at 3 months of correction, the alignment is corrected. And at 5 months, after removal of external fixator, the alignment is still well maintained. And on lateral view of the X-ray, you can see that the equinus deformity is already corrected and is maintained at 5 months post-operation. And this is the latest X-ray at 1 year post-operation. There is a medial osteophyte at the medial ankle joint. However, the ankle alignment is still well maintained. There is no deformity seen in this X-ray. At 18 months post-surgery, this is our latest follow-up for this patient. She was very happy and very satisfied with the treatment. Currently, she's able to walk unaided with painless ankle, and she has good ankle range of motion. She already graduated, married and employed. And regarding her daily activity, she's able to climb stairs, cycling and pray normally. And the most important thing is she has regained back her confidence and self-esteem. This is a clinical picture during 18 months post-surgery. Upon standing, we can see that the patient stand with a normal ankle alignment. No varus deformity noted in this X-ray. And patient are able to do heel rise. However, there's a difference between heel rise over the right ankle compared to the left ankle because patient has limited plantar flexion over the right ankle. This picture showing range of motion of the patient. Patient able to do plantar flexion up to 20 degree and patient able to dorsiflex limited up to neutral position. The normal range of motion of ankle is 20 degree dorsiflexion and 50 degree plantar flexion. However, the range of motion that the patient achieve is good because it's a functional range of motion. Patient able to walk with this range of motion. Okay, and this picture is actually showing the comparison between both ankle. And you can note here that the limited plantar flexion over the right ankle and also dorsiflexion is limited up to neutral. Okay, this is the gait of the patient. So you can see that the patient had normal gait. She had no antalgic gait, no limping gait, and I think our physiotherapists and also patient had did a great job for rehabilitation post-operatively. To evaluate the patient functional outcome and also emotional improvement after the surgery, we assess the patient by using a SF36 score. SF36 is actually stand for short form health survey. It is actually a measure of health related quality of life that covers 8 health domains. So in this result, you can see that the patient had tremendous improvement at the physical function aspect, from 25% to 80%, and for the emotional well-being and social functioning, patient actually improved so much and up to 100%. So based on this case, we can conclude that even though the treatment duration with distraction arthroplasty is long, but this method able to give patient with ankle arthritis and deformity a new hope and better quality of life. And we can see a good outcome physically and also emotionally, and patient is happy and very satisfied with the treatment.
Thank you, Ms. Noriana, for very well explained about how this clinically and functionally the patient now. So now we come to a question and answer sessions. If there is any doubt or any things that you want to ask regarding the cases or any things about the radiological part or rehabilitation part, maybe you can start asking the question now. Okay, right. You can see there is a 2 question. You can start asking question maybe now.
There's Q&A, there's one question, right, Prof, is it, in Q&A?
Yeah.
There's only one question in the Q&A.
Okay, I cannot see the question there. Alright. Okay. Alright. There is one question from Dr. Gautaman. Dear Dr. Tamizi, I would like to ask a question with regards to imaging options to assess chondral injury in patient with implant near the ankle region, in which MRI image will have artifacts which will impact our assessment of chondral injury. Any imaging options without the needs to remove the implant? Any role of cone beam CT in the assessment of the chondral injury? Well, maybe Dr. Tamizi can help answer the question.
Hello, Assalamualaikum warahmatullahi wabarakatuh. So, okay, regarding the question, which is in which MRI image will have the artifact in which will impair our assessment of chondral injury. Okay, basic rule is any implant or metal implant have a ferromagnetic effect. So either titanium or stainless steel have this. So as long as the metal component is very near to the respective thing you want to see, it can affect the adjacent ligament because it can have this blooming artifact. So that's for the artifactual. So if the component is away from the region of interest, the blooming artifact is much more less lah. If you use the titanium, the blooming artifact is much more lesser compared to the stainless steel. Okay, for the second imaging is any imaging option without the need of removal of implant. Okay, as we know that ultrasound have the almost par or equivalent quality of in terms of assessment of the ligament, but have the limitation. For the ankle, we can assess the ATFL, CFL on the lateral view. For the medial, we can assess the superficial and deep deltoid ligament on that. For the deltoid ligament, only the tibionavicular, which is not that superior in terms of assessment, but the rest we can assess on that. For the third imaging is any role of cone beam CT in assessment of the chondral injury. Not much, I think, cone beam imaging, because we in our CT scan nowadays is we have a very thin slice, and the image quality is almost what we call that is best in terms of assessment of bony part of that. But still, MRI have a superior in terms of assessing the cartilage injury, unless there is some implant that can lead to this blooming artifact. CT scan is another option to use to assess the part of the collapse or crumbles of the fracture site. That's possible my answer. Thank you.
Thank you very much, Dr. Tamizi, for the answer. All right. There's one question from Dr. Fauziana. If we diagnose the arthritis early, is there any role of arthroscopic intervention? Yes, if we diagnose the patient early without any deformity, only because of the pain, we can do an arthroscopic intervention and debride all the and around the joint and clear the soft tissue impingement or anything. So there is a role of arthroscopic at that moment. Okay, there is another question here. Salam and good morning, Ms. Dana. can we use monolateral external fixator for a distraction arthroplasty?
Okay, thank you for asking. Actually, for distraction arthroplasty of the ankle, you can use monolateral external fixator. However, the limitation is monolateral can only do distraction in one plane. And also the drawback is monolateral fixator, you cannot achieve an equal distribution of the distraction forces, and you can has difficulty when you want to apply it across the joint, because you need to apply an axis or the hinge of the joint. So circular external fixator is actually a better option because it you can achieve more equal distribution and also more stable. And another advantages is you can do multiplanar correction. In this patient, for example, you can do, you want to correct the deformity in few planes, right? So you want to correct the variance deformity, the inversion, and also the equinus deformity. So external circular external fixator is better. However, for monolateral fixator, you can use to distract small joint, for example, like tarsal metatarsal joint or metatarsal phalangeal joint.
Thank you, Ms. Lena. So actually, the distraction using a TL hex support gives lots of benefit towards the patients. It's not only corrections of the deformity, but at the same time, then if the patient can control the mobilization, we can advise the patient to walk with using the TL hex support. Okay, is there any other question that need to be answered? Okay, there's another question here. Is there any role of injections of PRP? Okay. The role of injections of PRP, as you can say, there is a non-surgical part management of the osteoarthritis. It can be done. There is no harm of doing it. But as you know, the role of injection and PRP is more towards a temporary relief rather than a definitive kind of treatment. So in this kind of patients who have severe ankle arthritis, the injections and the PRP usually most of the times will not work. So the surgical part of the patient is needed to be addressed in these patients. Okay, there is another question from to Miss Ai, our physio. Is there any role of wax therapy in ankle OA?
Thank you, Prof, for the question. Actually, yes. So the wax therapy is the same like the thermotherapy like that. Just only compared to the hot water bag, it's more deeper inside to the tissue and ligament. But the wax normally you only can do in the physio unit. Compare is hot bag you can do at home like that.
Okay. Is there any other burning questions? Okay. I think there is no more question regarding our patients or anything about ankle arthritis. So before I end these sessions, I want to just give a key learning points towards this case in which, as you know, the limb deformities usually give an impact towards our patients, either the quality of life, mentally and also emotionally. So in a young patient with any asymmetrical ankle arthritis, most of the time, the joint preserving surgical technique is better than to do a arthrodesis. And by using a distraction arthroplasty by external fixator, it have given a good outcome with a better quality of life for patients with a severe arthritis. So as we noted in our topic, this is a new beginning instead of the end. So as I can say that is that our treatment, there is a lots of treatment that can be addressed towards the ankle arthritis. So if there is any problems towards the ankle arthritis, we can explore any new things that can make the patient have a better quality of life and can improve her mental and emotionally. So without any other question, I would like to thank you again for all the committee members that involved in the Clinico-Pathological Conference in helping us to make this session a successful one. And then with that, I would like to continue with the cohort question with the undergraduate student. With that, I thank you. Bu, Assalamualaikum. Bukhari, can we start the cohort session?
Okay, Prof. Thank you.
Okay, for a medical student, okay, there will be a Kahoot question session now. So there will be about 5 questions. Okay, who reached the platform, the three most highest scoring. Okay, I will give some present. So you need to try your level best to get to the podium. Okay, if you earn it, you can come to foot and ankle ward in orthopedic to get your prize. Okay, now we will start with the Kahoot CPC orthopedic. Masuk. Waiting for players. Oh, 9. Jom, hadiah besar ni. Gambar domino. Bisa. Okay, tahniah pada yang menang. GA0219 and A170290 and A168119. Okay. For all the winners, you can come and take your prizes from me, okay? Especially today only, if you come late, cannot get the prize. Okay, I'll be waiting for you now in the food and anchor ward in near the orthopedic mill. So come and grab your prizes. And for the student, hopefully you guys can benefit towards all the discussions and also what we already discussed about during this time. And then hope to see you again next time. And with that, I would like to thank you everybody for joining us for this CPC of Orthopedics Department. Thank you again. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you so much, Prof. Barcode yang dibacakan ni untuk doktor untuk doktor menggunakan apps MMA. Menggunakan apps MMA. Okey, untuk doktor saja menggunakan apps MMA. Untuk partisipan dan juga doktor juga boleh isikan link yang saya tuliskan di chat. Sila isikan link yang saya tuliskan di chat untuk catatan kehadiran. Terima kasih.
Bu, panel tak bayar ke Bu?
Panel sekali.
Sekali Dia buka lah pula.